Good afternoon, everyone. Hope you're having a wonderfully insightful afternoon. My name is Jane True. I work at Pfizer. I'm responsible for mRNA commercial strategy and innovation, also our global pandemic security lead. It is my pleasure to introduce the next panel, How Philanthropies Influence the Nation's Health, featuring panelists Joseph Betancourt, President of the Commonwealth Fund, Sandra Hernandez, President and CEO of the California Healthcare Foundation, Kara James, President and CEO of Grantmakers in Health, Mark Miller, Executive Vice President of Healthcare at Arnold Ventures, and moderator Elliot Gerson. Elliot is the Executive Vice President of the Aspen Institute, responsible for its policy programs, public programs, and relationships with international partners. Mr. Gerson also administers the U.S. Rhodes Scholarships. He was a Rhodes Scholar himself at Oxford, a U.S. Supreme Court clerk, has practiced law both in government and privately, has held executive positions in state and federal government, and on a presidential campaign, and was president of startups in healthcare and education, including two leading national insurance and healthcare companies. As a lover of the arts, he has also served on many nonprofit boards in the sector, so I cannot think of a more suitable person to lead this panel discussion as someone who understands what it takes to get big ideas off the ground. So again, please join me in welcoming these panelists, Joseph Betancourt, Sandra Hernandez, Kara James, Mark Miller, along with moderator Elliot Gerson.
Thank you. Goodness gracious, I haven't had that long an introduction in years. I didn't even recognize most of those things, but thank you very much. I am always delighted to have a chance to moderate conversations at Aspen Ideas Health. I can't see very well to know if Ruth Katz is here, so I can embarrass her, and possibly Peggy Clark, who were the co-creators of Aspen Ideas Health 10 years ago. And it was great from the outset, and it just gets better every year. And one of the things that I think makes it so special is not only your ability to attract remarkable people like this, but remarkable people like all of you. It attracts people who care deeply about issues, but particularly health issues, and creates a cohort of people, in many times coming back year after year to explore some things at the frontiers of healthcare, and both the science and the medicine and the delivery of it. Today, as you heard, our conversation is going to be about how philanthropies influence the nation's health. And the short answer to that is very deeply and in myriad ways. And I think it's also important to note we have a global audience here, that we are almost uniquely blessed in having a philanthropic sector that has such profound impact in healthcare. Unrestrained by the need for profit, or at least balanced budgets in the private sector, and not affected by politics, either in the best sense of the word or in the often dysfunctional sense of the word. Philanthropies, of which we are richly blessed in the United States, really have enormous impact. And we have here today, as you heard, 4 people leading extremely important philanthropies. 2 of them I want to especially thank for also supporting, as underwriters, this enterprise. So I'm just going to ask some general questions, and then I hope all of you will jump in with questions as well. So, because we have a group of people here who can share their insights about what the philanthropic sector contributes, some of the most urgent issues as they see them, and what still needs to be done. Now I see Ruth Katz coming in, so I don't have to. She missed my embarrassment. So let me start perhaps with Sandra, and then I'll probably ask a similar question to each. Coming to Ideas Health and being exposed to the enormous number of challenges and opportunities, how do philanthropists establish priorities? Given all the opportunities and at the same time all of the challenges, and with limited resources, how do you decide how to focus?
Well, it's nice to be here. I would say, if you think about the state of California, where CHCF operates and where our bylaws and mandate have us work, there is actually quite an extensive ecology of philanthropic organizations, from community foundations to family foundations to large healthcare foundations to healthcare foundations that are sponsored by plans, conversion foundations such as the California Healthcare Foundation. So I think part of this is understanding what all of us do collectively as sister organizations, all of us trying to promulgate the best possible health outcomes we can for a state of 40 million people. So for California Healthcare Foundation, we have really stayed very much in the lane around the healthcare delivery system. We could think about health in very broad ways. My background before I came to philanthropy was in public health. We don't do a lot of public health unless, of course, you're in the middle of a pandemic, in which case we, like all foundations, got into that. But so California Healthcare Foundation has really tried to, I think, do three things well. One is to take advantage of the federal environment and the opportunities that come to California to improve the delivery system, with a particular focus for us on low-income communities and communities who have historically been very poorly served by our healthcare system in California and actually in the nation. And so we, in that lane, in California, it's pretty hard to not focus on the Medicaid program in California, which is the, we call Medi-Cal. California has been sort of policy forward and healthcare forward. When ACA came into effect, California was one of the first states to stand up a health exchange, covered California. And CHCF was very involved in that work. We have been on a very steady path in California to ensure that everybody gets under the health insurance tent. California has a very large immigrant population, a very large farm worker population, and a very large undocumented population. And over the years, and I've spent 35 years trying to steadily get more people in coverage. And so getting people into coverage and then making sure that coverage actually provides them care that is evidence-based, that's timely, that meets them at their needs, and really thinks about them in their entirety. And I would say that, we've talked a bit at this festival. There's been some fascinating conversations about information and communication and how you share that. And CHCF has had a very long history of really providing the kind of data and evidence that would inform good policy. And so we have a very strong policy lean. And we, of course, advocacy partners that help us with that. And we play this dual role of both trying to push our state government partners to effectuate their programs well, and also to help them execute those well. And lastly, I would just say that it's a big state. We are a diverse state. We're a diverse state politically. We think it's really important to have credible evidence, credible data, and to have journalism be alive and well to keep the healthcare conversation grounded in what the issues are in California. And so we have a big program in that. And lastly, because we work in the delivery system, we've also thought it really important to lift up clinical leaders. My predecessor started a program, a clinical fellowship program, to take leaders that are in delivery systems, whether they're public systems or private systems, and grow that capability for transformation from within. And so that's kind of how we, broadly speaking, approach our work. We operate with a lot of goodwill with our sister organizations, some of whom are doing power building, others who are doing domestic violence, others do more public health work, and we've pretty much stayed in the healthcare delivery space and taken advantage of both federal and state leadership as we think about going forward.
It's fascinating, and as in many things, California is a leader, and the way that you're integrating all of those things together is really an inspiration for lots of people. Mark, Arnold Ventures is really known for driving change and really actively committed to change. And we've been fortunate at the Aspen Institute in any number of areas outside of health to get support from the Arnold Foundation. I wonder, as you joined there from your experience in healthcare, how is that passion for driving change manifested in the context of healthcare, and what your priorities are?
So, to connect to that question and the first question of like how we chose what we, and I see this as very complementary to what you said. Of course, you can decide if that's correct. I think a lot of philanthropies have focused on things like coverage, quality, that type of thing, all good, or supporting research and disease. The direction that we've taken is affordability. And I took this position 5 years ago and was concerned about the fact that philanthropy hasn't spent as much time on that. And our focus is to look at market failures or to look at ways that government programs are kind of misspending, dollars. I imagine there's some sponsors here that are going to not want to hear all of this, but managed care organizations taking advantage of payment systems, hospital systems taking advantage of consolidated market positions to raise their prices. How we think about it is we think that this is a broad-scale issue that is worth taking on. If you just think of affordability for businesses, for households, and for taxpayers, which is the orientation we're trying to come from and represent in the debate. So we think it's important. 100 million people with medical debt, that type of thing. We all kind of face it. We also think there is traction to be had. We think, and I can get into it, but there are specific policy changes or specific market interventions that can, in fact, have an impact. We also look at the environment of whether it's federal and state, and is, beyond the evidence, the policy, which, we try and generate, are there coalitions, partnerships, people in states, or whatever the case may be, or at the federal level, that you could work with to move that? And we try and make an assessment there. I think we're driven by the costs or the spending concern, the affordability concern, both in order to make what is currently available to people, to be sure that there's access, but also to the extent that there are new things, expensive drugs, new innovations that are going to add to cost of the system, maybe you could better spend a dollar that you currently have, that you're currently misspending. So I think that's kind of why we've gotten into it. And then I've tried to define the circumstances that we look for. It is very much about, when assessing a situation or assessing a project or whatever, like, what impact will this have? And also thinking about, like, whether we should go through the state route, go through a federal route, market disruption, or a government change in policy. I'll stop there and ask if I still remember the question.
No, you answered it very well. No, and I think it's especially interesting that, with so much at the cutting edge and funding things at the cutting edge, to recognize that affordability is such a fundamental problem that philanthropy can contribute to. Joe, let me just go to you and find a way to also talk about, what your priorities are. You've been in this job, 6 months or so?
4.
4 months. So what, and he was telling me backstage earlier, he still spends a couple of days with patients and teaching at Harvard Medical School, and it's great to be still connecting in that way. What are your biggest surprises joining the world of philanthropy, and then what does that translate based on your clinical experience into what you just, learning about the Commonwealth Fund and the opportunity are going to set, you think, as your priorities?
Yeah, well, thank you. And thank you for choosing us. I know you had a lot of options today, so we appreciate you being here. Look, I'm blessed to assume the leadership of an incredible 100-year-old foundation with a phenomenal team, just really impactful history. So, I live with that gratitude in every one of these close to 5 months now that I've been in this role. This is a foundation that now has as its mission affordable, high-quality healthcare for all, with a particular focus on vulnerable populations, which couldn't be more aligned with my kind of, life vision. Clearly, I think this foundation has been so impactful historically, funding the first public health departments, medical schools in urban areas, rural hospitals. That operational support early on, I think, was transformational for U.S. healthcare. But then the foundation pivoted and really has tried to leverage its fairly modest resources to be impactful in the areas of policy, with a real focus on coverage and access, certainly more in the area of health equity, international work. We have work that connects, I think, to what Mark is talking about, delivery system reform, cost control. So we have 8 programs, too many to name now, and also doing work on climate, behavioral health. We do a lot of work on public health, which we've now folded in. So to me, it's an embarrassment of riches. We have a lot of assets and very smart people now. So as I assume this role really, I guess the last thing I'd say is the Commonwealth Fund was incredibly important to me in my career. That's what makes this opportunity special. In 1997, I did a fellowship called the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. Second year of a fellowship that was supported by the Commonwealth Fund to really advance individuals like myself. I'm originally from Puerto Rico, minority healthcare professionals on a path towards leadership. So they touched my life very early on and gave me some grants along the way. So a long way of saying not only have they been impactful, but they've been impactful personally and professionally to me. So as we look at the future now, it's really about taking stock of how we do leverage those assets that we have and the resources we have to be most impactful. Again, I feel like we have that history. We just released a state scorecard yesterday that we release every year that I think is very well received. We do some international comparison work. So, my job has been to listen, learn, and now figure out how do we maximize the impact we've had and think about taking it to the next level. I have some areas of interest, and I guess maybe I'll end by saying that I'm driven by a life's worth of experience outside of philanthropy, being a very careful student of philanthropy, and also, although I've done the majority of my work in the area of health equity, been a very careful student of all aspects of health and healthcare, because it was only through being a careful student of those places that I felt like I could get equity built in, not bolted on. And for me, I think I value the importance of where we are and the expertise we have, but I do not want us to be an ivory tower. We need to lead with humility. I'd say, another key principle is that we have a portfolio of work, and some of it will be tried and true, and some of it will be innovative, and I'm excited about what that might bring. I do believe that there are big problems like climate that we alone cannot solve, and so partnership is going to be essential. And we're always going to be challenged by impact. How do we get the most out of our resources? And certainly, given my interests, I want to make us the best foundation in the nation on the area of health equity. So excited. The opportunity is wonderful, and I'm accompanied by just a phenomenal team and great partners to accomplish that.
Well, thank you. And Kara, with Grantmakers in health, the pandemic, made it apparent to everyone what was obvious to people like you before, which were the extraordinary disparities in healthcare, especially on racial disparities. And I wonder if you can talk a little bit about how your foundation is working on addressing inequity in healthcare, which is a theme that's already emerging here.
Yeah, so first of all, thank you all for inviting me to be here. It's great to share the stage with colleagues like Joe and Sandra and Mark. So Grantmakers on Health is not a foundation. everybody thinks we are, but we actually are a philanthropy support organization. So we work with foundations such as California Healthcare and Commonwealth and others to, in service of better health for all through better philanthropy. So we work with over 200 foundations and corporate giving programs across the country to do that through convenings, through education, through surveys. So when we think about, what happened during the pandemic, and Joe and I had the pleasure of working together when I was at CMS and directing the Office of Minority Health, we saw a lot of, the pandemic showed light on so many things. Just pick your topic, pandemic showed light. We saw with equity, we surveyed our funding partners around how they were pivoting in September of 2020 to address the health inequities that were coming to the forefront and the social unrest that we were seeing. One of the things that I'm pleased to say is that many of the foundations were already in the health equity space. So, organizations such as the one I'm sharing the stage with, others in the room, were already in that space, but they deepened their efforts. They expanded their efforts. They created new initiatives. Some of the questions that we asked them were, are these going to last? What we found at that point in time was that a lot of them were still trying to figure it out in terms of where they were going. So that speaks also to the breadth of foundations. There's sort of an expression, if you've seen one foundation, you've seen one foundation. We have nationally focused, we have state focused, we have smaller community focus in their work that they do. Priorities somewhat set for some of those conversion foundations from the Attorney General in terms of where those focus areas can be, but also you have others in the breadth of things that we think about in health in all places. So that's a little bit about how they've responded. Like other sectors, they hired new people to lead health equity initiatives, hired diversity, equity, inclusion officers, and we've been working to try and help them, strengthen them, and shore them up to be able to set up for success.
Thank you. Sandra, back to you. You already talked a little bit about California and things going on there. Obviously, it's making enormous reforms in healthcare delivery that will affect millions in other states as well. Can you just tell us a little bit about some of those that you think are most significant and what the implications will be? For example, we're reading about, Medicaid contraction in so many places, yet in California, it's expanding to, potentially, 1 million undocumented. So just tell us about what is happening in California and what it's going to mean for everyone.
Well, so many foundations across the country and many of the health foundations in California have been working on coverage for many years. Those have all been very incremental steps where the philanthropic organization has been super helpful in working alongside our government partners. In January of 2024, regardless of your documentation status in California, you will be eligible for state-only Medi-Cal if you do not have documentation. It essentially eliminates anybody in the state who isn't eligible for some program. Getting them enrolled is another issue. But that has been a very steady journey, and it's been done in partnership with a lot of advocacy organizations. It's been done in partnership with the state legislature, and Governor Newsom has come in and said, we're going to finish that work. CHCF adds value in that space. Focus groups, what does it take to get you re-eligibilized? We talk about the pandemic and how disruptive it was to so many societal things. Imagine how many people who were on Medi-Cal who moved during the pandemic, who had to move or who did move. So the lift to get people into programs that they're eligible for is really the next phase of our work on continuing the coverage piece. And I think, California's 40 million people. We're an enormous state. We're incredibly diverse. And so I think in that regard, we are probably leading the country for sure. The 1115 waiver has been a tool of Medi-Cal, Medicaid in California for many years. This is an administration that said we're going to go further with the 1115 waiver. and created a program which we refer to as CalAIM, which has a very specific, keep in mind that California has been in managed care for 25, 30 years, so much of the implementation and execution happens through health plans. And CHCF does a lot of work with health plans as partners to have them be able to execute on a lot of the opportunities that are in the waiver. The waiver is built on a concept of whole person care. What a concept. When we talk about humility, one of the ways that CHCF sort of keeps our feet on the ground is regularly polling low-income folks to understand actually what they need, what they perceive as their priorities. So it's not just those of us who look at data and produce data and think is important, but actually talking to folks and hearing what their priorities are. And that's been super helpful to us and to the state, which, by the way, the mental health shortage and workforce shortage pre-existed the pandemic. We had just done a survey before the pandemic where low-income folks said their top priority was getting access to behavioral health before the pandemic. But the whole person care work that the state had done, working with a lot of the safety net, the public hospitals, community clinics, really had been trying to look at the population that is hardest to serve. People with multiple diagnoses, people who are unstably housed, people now who are leaving our criminal justice system. New waiver that CMS just passed allows for the first time for us to begin to do Medi-Cal work 90 days before somebody gets released from prison or jail. That has never before been the case in any state anywhere. California is already sort of the cutting edge on what the idea is. Where CHCF finds our strategic niche is to test those ideas, to try to figure out where the bright lights are, to document the bright lights, to try to bring along folks who are interested but don't yet have the capacity to do that. And we support a lot of learning collaboratives so people can learn from folks who have tried that, it worked, or tried that and it didn't work. But I think California has used the waiver process to really modernize the Medicaid program to be able to integrate behavioral health with physical health at the same place. I mean, one of the things that happened in the pandemic, literally from one day to the next, we had been in telehealth and telemedicine for 8, 9 years, and just were getting no traction, largely because there was no revenue for it. And then the pandemic happened, we flipped a switch, we went to our board and said, we need to be able to do telehealth in our federally qualified health centers, which really had never been able to do that before. So there were many things that happened in the pandemic that accelerated some of the reform that the state had been looking at doing and that we had been investigating and trying to shed the light on. Doing much more intensive case management, a great deal more focus on people who are unsheltered. CHCF just did sponsored one of the most comprehensive surveys of people who are unsheltered in California. If you haven't seen it, it's really worth doing. We have a lot of ideas and stigma. We have a lot of homelessness in California. People sort of think it has to do with drugs or it has to do with mental illness. Actually, it has to do with affordability of housing. So poverty, which everybody knows, is a major driver of disparities, and we see that literally in the streets of California. So again, staying in our lane, really. And by the way, California doesn't test everything for the first time. One of the other things we do is sort of say, what's going on in Oregon? What have they done on cost containment in Massachusetts? So that we try to bring that information, package it for legislative staff and legislators so they can sort of say, oh, well, Massachusetts has been at this for 10 years. How does the state of California go at affordability? And so we play that role of both. I mean, we're a statewide foundation. We're not afraid to fund outside of the state if we think it can help California and vice versa.
Thank you. Mark, we had a short email exchange before coming out here, and you raised, I thought, a fascinating question. It sort of relates to my comment earlier about how philanthropy plays a much bigger role here than perhaps any other place in the world. And you asked the question, why does philanthropy have to be involved in the first place? And I wonder if you could sort of address that for us.
Wow. I'm sorry I asked that. And I also want to say a couple things about the last question. But why philanthropy, should be involved? I think one of the most important reasons is that you can enter a discussion, a debate, however you want to talk about it, and come at it with no financial conflict. Okay? I mean, what Arnold Ventures does is it hemorrhages money. That's what it does. The founders have, come into wealth. They have decided that they are going to spend it out during their lifetime, and that's what we do. And so people attack us and say, well, you have a specific position on this, and that's what I do. But what I don't have is a financial conflict. I think there are other things. You mentioned the partisanship. You can try and, bring people together, walk that line. It's harder or easier depending on whether you're talking about the federal or the state or what the issue is, certainly. But you can do that. I think that one of our missions, and I think this is true, is speaking for people who don't have a voice in the debate. The kinds of things that I can point to that we were involved in, like the No Surprises Act to end surprise billing, the recent Medicare drug legislation. There are very formidable, groups with a lot of resources and standing that opposed all of those changes and are currently in the courts trying to undo them. So I think you can kind of speak for, in our case, the people who are paying for everything in the end. You can choose the issue and you can stay focused on it, which is sometimes hard for governments, I think, to do that. You can also choose the theater of operation. Should it be the state? Should it be the federal? That type of thing. The other couple things I'll say is, depending on the issue, even if you're out, like the level of funding that your opposition has far exceeds what you have, you can make your dollars count for more than one if the public is on your side. So a lot of people, Republican, Independent, and Democrat, wanted changes in drug policy. And so, the opposition was working uphill because of public sentiment. We had fewer dollars, but we had public sentiment on our side. The other thing I would say, I don't know if this is so much to your, why philanthropy, but how we think about things and how I would urge people to think about them is, there's evidence and idea and education. But if you really want to affect change, you've got to go further than that. You've got to build coalitions. You've got to push for legislative change or change in the market. We can talk about that if it comes up. And I think philanthropy can play a role that sometimes not always, but can play a role that other organizations can't. Beyond the No Surprises and the drugs, there's been some recent legislation introduced that we have been, kind of working on and bringing evidence to, integrating Medicare and Medicaid for the dual eligibles,
Yes.
for example. There's been hearings recently on something called site neutral, beyond the scope of this to discuss it unless you want to ask, but it's about prices and sort of prices that are out of sync. There have been states like California, Massachusetts, Texas, and Indiana, all that we've worked with, who've looked at this issue of highly distorted prices. And then recently there was an attempt on the part, or the administration, to get a handle on the coding issue in the Medicare program, and we put a lot of resources into that. So those are some of the things. And if I could just mention one other, in the hospital sector, there were low-cost generic drugs that were constantly falling in and out of supply problems. And with West Health and Peterson and ourselves, and Sherry sitting right there, we worked with some hospitals to develop Civica RX so that they could actually begin to manufacture those drugs for themselves. But I'll stop here, I'm sorry.
Well, thank you. Joe, again, is the newbie in philanthropy and related things. And I don't know that we'll be surprised by your answer, given what you said earlier about your own background and your focus at Mass General. But with what do you see as the biggest issues in healthcare today?
Yeah, I mean, I think what I really want to bring in this role is that experience from, the doorstep to the bedside. I want to make sure that the work that we're doing is not, policy esoteric, that it could be meaningful, that our audiences, the people for whom our foundation, fighting for every day, could also understand what we're fighting for, and we bridge that gap. So I just want to say that as well. And that will be informed by my previous life of, being a healthcare executive, really devoting myself to vulnerable communities. I'll say that there are a couple things that come from that life that now ring kind of true to me as areas of concern. I think the work that we do is phenomenal, but there are a couple of other areas too that I'm thinking about. And some of these should be not a surprise to a lot of folks. I mean, what's happening with artificial intelligence is incredibly exciting, but when I think about vulnerable populations and when we think about how algorithms are made, and we already have evidence that algorithms can be made and have disproportionate impact, I worry about that quite a bit. I think this is a bit of the Wild West now. And so I think there's a place, and we've been having conversations just this morning about ways in which we can collaborate to think about what are the guardrails and considerations as we advance artificial intelligence with a particular focus on people and equity. Another one, and I think Mark alluded to this, is we focused a lot of our attention in the healthcare space, and a lot of attention has been given to the social drivers, social influencers, social determinants. Name kind of changes every couple of months, but fundamentally, those things are very, very important. And there's a new moniker emerging, which is the commercial drivers of health. And a place where we're at where I think I am fundamentally concerned about many situations where dollars are being put in front of people's interests. Now, some may say, well, that's always been the case. What's new? I would argue that this is a pendulum that's swinging quite far. I don't have a position about right or wrong. I have some feelings about it, but I think this is something that we need to get engaged in to better understand and shed some light on. And I guess two clinical ones that are really important. Certainly mental health, behavioral health are a major issue. Our work on maternal health and reproductive health, given where we are in this nation's history, is going to be very important. And I really, I'm very concerned, like many, about workforce. And I would just say that on the workforce issues, there's a lot of discussions around shortage, a lot of discussions around fatigue and burnout. But, we as clinicians have worked hard for a long time. And I would argue that what we've seen now is a time as caregivers where we just came out of the most difficult but most adrenaline-producing kind of situation in our careers, saving lives in that moment during the pandemic. And then we come back to this real life where, things like that seem nominal to us, trivial to us, that now are part of the administrative burden that we have to experience, they're really painful. Mm-hmm. And there's a lot of people who've written about moral injury, administrative harm, kind of this demoralization. And I will tell you that is very real. It's real. I experience it with my colleagues. A loss of a sense of agency. Now, again, I don't want to put the privilege up on a pedestal. I understand healthcare providers, we do quite well, and nurses and others. I mean, we definitely are more privileged than some of the people who I care for. That being said, I think we are seeing generationally a new group of healthcare givers who really want to put their patients first. Mm-hmm. And losing agency in that process is not something that they're willing to do. And we're seeing it. It manifests with unionizing an organization, and you could track that. That's just one reflection of that. So those are a couple of areas. Now, I don't want to speak out of turn. I'm 4 to 5 months in, so I'm not, there's no dollars coming exactly in the space quite yet for those of you who are interested. No promises, but those are areas of interest, and I think, I don't think we're going to solve them on our own, and I think we're already exploring partnerships in those places.
Kara, just continue along the sort of aspirational element of all of this, not as a philanthropist, but working with philanthropists. I mean, what do you think are the most important things today that philanthropies should get more engaged in than they are now?
I think I want to double down on something that Joe said about the workforce. And it's not just the healthcare workforce, but given that we're talking about, as he said, whatever your moniker is, social drivers, social determinants, that we're thinking about from conception through death, the care that people need, and that we have a situation where long-term care providers, nursing homes, home health aides, the people who care for some of our really, really, really most vulnerable communities qualify for food stamps. I mean, that is just, it's unconscionable. I mean, that we're paying people so little that they are qualifying for food stamps. That we're having conversations about, well, if you increase the wage, then it's going to kick them off of those programs because they're not making a livable wage. But who's going to care for our communities when we really need them? They are the essential workers who allow us to go to work and do all the other things. They care for our children, they care for our parents and our grandparents. And it's that workforce that is going so much beyond even the hospitals. When we think about our rural communities, we are losing rural hospitals, that we're seeing, rural providers leave those communities. Who's going to provide the care for those communities? And is it acceptable that we're having pregnant women who are in rural communities driving 90 minutes one way for a 30-minute visit? That's kind of, we're losing a lot of that. So our workforce is a space where, the Affordable Care Act had a workforce commission that never got off the ground, but I think the need for that in the last decade has only grown. And that's a space where I think philanthropy really could and should step in a little bit more to help us think about how we are training, how we are making sure that we are creating pathways for people to come into that space, to have a livable wage, where we're having medical students graduating with $360,000 in debt. When we think about diversifying our workforce, that's not a tenable situation because it's not affordable. So that is one. I think the other thing is we are seeing a moment unlike anything we have seen on our focus on equity. But I'm a little cynical, so when I think about the last time, in 2000, we had the Minority Healthcare Improvement Act that established the unequal treatment report that Joe and Sandra and others were part of, that established the National Center for Minority Health and Health Disparities at NIH, that established the unequal treatment report. And then we saw a little bit of a dip. And then we saw a little bit of an increase with the Affordable Care Act, and then we saw a little bit of a dip. And we're seeing an increase right now, the sustainability of that focus, because 400 years of creating inequities aren't going to be solved in 2 or 3 years. So what is our long game for that, and how are we making sure that we commit to that? And philanthropy is committing to that, and committing to the organizations that we work with and through to do the work so that they too are here for the long game. So those are just 2 of the things that I think a lot about right now.
Thank you. And we can all add to the list, and let you all add to the list in the time we have. And we need the microphones. I see there are a couple over here, and I don't want to miss this side over here. So if you can pass the microphone there, and then we'll move up to the front here, and then come here. Thank you.
Yeah. Oh, go ahead.
Oh, go ahead.
Oh,
Are you sure? All right. Thanks for the panel. I'm with the Center for American Indian Alaska Native Health. I'm a tribally enrolled member of the Metlakatla Indian community from Southeast Alaska. What's been really discouraging as I've entered this space of health, especially for tribal communities, is foundations and philanthropy, as you all likely know, only contribute about less than 0.5% of those foundation dollars go to tribal community members. And so as you're talking about sustainability, I was thinking, how do we even reach some level of even equity? And so what are the strategies for that population specifically, if that's something that you're thinking about? But we talk about vulnerable populations. I myself don't find our communities vulnerable. I think we have a lot of strengths. I think that we have a lot to offer. But I do think that we've missed the mark in terms of disinvestments. We've missed the mark in terms of a host of other structures that we have put into place. And so what is your response to how can we serve those populations in a much more meaningful way that really does get at rural, hard to reach populations?
who would like to?
I can start a little bit. So we work with Natives in philanthropy as well, and so Native Americans in philanthropy to engage in some of that. I think we're also seeing a number of foundations at this moment think more critically about their community outreach and their engagement and who they are engaging with and how to reach some of those communities that they have not typically engaged with, and some of the grant making. That's something that has happened over the last couple of years. I think also sort of how we are bringing those voices in and having that meaningful community engagement. And Sandra talked about some of the surveys that she's doing, but others are thinking about those opportunities to do outreach in that space. And then lastly, I would say, with the National Rural Health Association and others, we have been working to include more tribal voices in the conversations. There are some foundations like Kellogg who have had a long history of engaging with tribal communities, more in sort of the Southwest space, but there are some who do a lot of that work. But there's clearly more that can be done, and we welcome that opportunity to help us identify who some of those voices and leaders are in the community that we can work with.
In the limited time we have, we're going to go to other questions, although I'm sure everyone would like answering all of these.
Talk to you afterwards.
And Joe will talk to you afterwards about it.
Hi, I'm Jackie Gerhardt. I'm a family medicine physician at Epic and practiced during the pandemic. I love that you all came up with solutions. It's really refreshing to hear things that you've actually actively put into place. We saw during the pandemic some really great solutions like changing the way that clinicians are credentialed, or advancing telemedicine, or figuring out how to get that patient that lives 90 minutes away to be able to take it at their home rather than have to drive that 90 minutes. What are some of the things that you saw as solutions that came out of the pandemic that we might be slipping on, that we might be actually going back into, old thinking that we could actually use your help in advancing?
I mean, I just say everything about the pandemic. I mean, we used to talk about this, so on incident command, and you were probably involved in this, right? We would say, God, could you imagine in normal times, like it would take so long to get this done, and we love that. And yeah, we're up 7, 8 o'clock at night, 9, doing calls, Zooms, but you were living for that moment, and you almost laughed at those times before the pandemic. And we always said we need to have the courage to bring these lessons forward. If you and I were trying to work on something, Jackie, I'd reach out to you and say, okay, I need to talk to you, and we'd be on the phone in an hour. Now, we might get scheduled in a month. And I mean, to me, that loss, what we're doing in this nation around healthcare requires that level of urgency. If people don't think that the behavioral health situation is not a pandemic like COVID, if people don't think what we're seeing, around maternal health, some of the things that we talked about in our scorecard yesterday, and if we don't bring that urgency to bear now, slipping into these old times, I would say it's slipping into that is the biggest peril, just the operating mode. But clearly, I think, the areas that we're slipping in are the rapid innovations that we developed, and going back to, okay, well, now we need to figure out if we're going to do telehealth, how are we going to license people across states? Before, you said this is about saving lives. You were able to break through these things. And I'm really hoping that, especially for some of these other crises, that we can bring that energy back and really be bold. It's just not easy. And that's the most frustrating part, having lived in that cauldron like you did, and to now kind of fall into, I'll talk to you in 2 months. These problems we can't have that timeline.
And over here, I can't really see. I think there's a microphone right here.
Hi, my name is Joseph Musgrave. I'm the CEO of an organization in Ireland that we represent home health providers. So this is quite new to me. In Europe, generally, this is not a panel discussion that you would have of the role of philanthropy. So my read is that part of the reason for your existence is federal or state failure. So,
kind of.
I
guess.
Well, this is my outside perspective.
And market failure.
So what I'm interested in is which failures would you like to see recede so you're less involved, so you can get more involved in other elements of health and public health in America?
So the public servant in me just wants to acknowledge that I worked in public health for many years before I got into philanthropy. And
she was commissioner in San Francisco and for the county.
And the constraints under which our colleagues that work in civil service and in government are quite impressive, actually. And so, there are failures. Many of the programs that have been built We have put all kinds of bureaucracies and administrative obstacles in front of the very communities that theoretically they were designed to reach. I mean, many of our safety net programs are really full of sticky, obstructionist ways to get into those programs. And so I view the role of philanthropy not so much to be critical of the folks that are in those programs, because they're doing policy, they design them, you do all the sausage, and then you got to implement them on the ground. And there, I think philanthropy has a tremendous opportunity to sort of say, okay, how do we actually make these programs work that we work so hard to get the policies to do? But I think we have to understand that government has its role and its lane, not the least of which they do things year to year, because that's just the way it's done. You know, the comment about philanthropy being able to go long and to be able to learn and to share what you've learned, that's just not a luxury that government tends to have. And so I just want to acknowledge both sides of that, because I've lived on both sides of it. And I think, you know, I tell people who want to do philanthropy for a living, go work inside the systems and understand what they are, because it helps you understand how, from the outside in, you can build the kinds of changes you need to be able to build. So I just wanted to reframe that a little bit in defense of the folks who are in that lane, and recognizing that philanthropy has a different lane and ways in which we can make them better and partner with them. Workforce is a really good example, and everybody mentioned, I just want to name it. 5 foundations in California came together to develop a workforce report to bring to a new administration and say, here's the investment we need in primary care, here's the investment we need in behavioral health, and here's the investment we need in aging services. The response to that was the legislature and the government put millions and millions of dollars in just those programs. So I see these working hand in glove in ways that we didn't get the Workforce Commission we wanted nationally, but in California, there's tremendous investments going on today in workforce in those 3 areas, because the foundations came together. All of us were dabbling in workforce. We said, actually, we should have a plan. We should have a Marshall Plan for workforce in California, and that's what philanthropy was able to build. And the administration now is trying to build the capacity to implement that, and we'll help those organizations try to do that.
Well, that was a wonderful example of cross-sector collaboration, and I think a great thing to end on. Unfortunately, our time is up, but I'd like to thank all of you for being here, and particularly to thank this wonderful panel. Thank you. Thank you. Thank you.